Hi everyone. My name is Yaling. I am working as a clinical nurse researcher at the ED Research Office at the Gold Coast University Hospital in Australia. In this section, I'm presenting a scoping review of clinical profile, care delivery, screening tools, and intervention for older adults at the end of their life, presented to the emergency department. I'm presenting on behalf of our team members, Dr. Namet El-Saba, who is a ED registrar, and Gemma Brooks, who used to be a Griffiths nursing student. Now she's working as a new grade registered nurse at the Gold Coast University Hospital. And Professor Julia Quilly, who is the professor in emergency care in both Gold Coast University Hospital and also Griffiths University. So as we all know, our population is aging worldwide. In Australia, the aging population is projected to grow from 15% to 22% in 40 years' time. Statistics also shows that 22% of the 8 million ED presentations are made by older people over the last couple of years in Australian public hospitals. Relatively few older people presenting to the emergency department and die have a pre-existing resuscitation status, and around 3/4 of older people receiving aggressive treatments before they die. So this sometimes poses a challenge to ED clinicians working in an environment where acute care and trauma are often prioritized. And this is also one of the major reasons that we decided to conduct this scoping review in order to provide an evidence-based practice for older people presenting to our emergency department at the end of their life. The aim of this review is to provide an understanding of available research regarding end-of-life care for older people in the ED. And there are 4 sub-questions to answer the overarching questions in this review, including how is end-of-life care defined in the emergency setting? What are the demographics, clinical profile, care delivery, and outcome for people requiring end-of-life care in ED? And what published tools exist to assist determining end-of-life care in the emergency department? And what published interventions are available which are designed to enhance end-of-life care in the setting of emergency care? In our review, we used Joanna Briggs Institute Scoping Review Framework to guide this review process. We formulated our inclusion criteria based on the population, concept, and context. So the population is older people aged 65 and over. The concept is end-of-life care. The context is in the emergency department. And we only included English peer-reviewed articles and published between 2007 and 2018. We excluded the articles which did not meet the inclusion criteria. So in our review, we used a 3-step search strategy. In step 1, as we can see on this slide, we did an initial limited search on 2 databases. And in step 2, we conducted a full search on 4 databases and Google Scholar with modified search terms, keywords, and search streams. In the last step, we did hand search of the reference lists of all the included articles in our review. And this is the Prisma for chart we used to present this search and screening process. Initially, we had around 2,000 records to start with, and then we narrowed it down to 105 articles for the full test review. Eventually, we included a total 14 articles which meet the inclusion criteria in our review. Now, I would like to talk about the results of our scoping review. In our review, we identified there were only 3 studies reporting end-of-life definition. Overall, in terms of the study characteristics, as we can see in this bar chart, most studies were conducted in the USA, and there were 3 cross-country studies including Australia, Denmark, Australia, Ireland, France, and Belgium. And other 4 studies were conducted in Singapore, Italy, Australia, and UK, respectively. In terms of the study types, the majority of the studies were cohort studies, followed by interventional studies, chart reviews, and co-sessional studies. And all the included studies were in the MHMRC level of evidence ranged from 2 to 4, as we can see in this pie chart on the right bottom corner in this slide. So in terms of the demographics of the study samples, as we can see on the first table here, most older people presented to the ED were females. The mean and median age were between 70s and 80s years old. Almost 40% were from aged care or long-term care facilities. And in terms of the clinical profile on the second table here, the majority of older people were arrived by ambulance during the business hours, and most older people were triaged as semi-urgent and urgent. And the primary diagnosis included cancer, dementia, heart failure, respiratory disease, end-stage liver and renal disease. Older people often presented with the symptoms of pain, shortness of breath, nausea, diarrhea, loss of appetite, and weight loss. So for those who die in the emergency department, the majority die from the heart disease, cardiac respiratory arrest, and respiratory conditions. So in our review, 6 care delivery to older people at the end of their life presented to the emergency department were also identified. As we can see in this pie chart here, this included referrals or consultations to allied health professionals and specialists, including social worker, physical therapy, pharmacist, palliative care, hospice care, and geriatrics, and also having follow-up phone calls from 1 to 14 days up to 6 months after discharge from ED, and also having nurse liaison, family conference, discharge plan, and documentation of end-of-life care plan, advanced care plan, and advanced directives upon ED admission for those older people. So in terms of the outcomes of the included studies in our review, unfortunately, no studies reported waiting time to be seen by a doctor in the emergency department, and 3 studies reported the ED length of stay were between 2.4 hours and 9.5 hours. And almost 60% of older people presented to the emergency department were admitted to the hospitals. And in 3 studies, around 47% to 79% of older people identified to be at the end of their life actually die in the emergency department. And 60% of the death in the emergency department actually occurred outside of the business hours. There are also a number of published tools that we identify from the included studies in our review. As we can see in this pie chart, we categorized all these tools by 9 health domains, and the most used tools by the health domain were assessment of functional status, followed by the mortality, cognition, palliative care needs. This is one of the 3 tables, shows all the identified tools under each health domain. I'm not going to specifically describe the tools here, but providing an overview of the identified tools in our review. In our review, we have identified 3 tools for the assessment of mortality and 7 tools for the assessment of functional status. This table also shows there are 2 identified tools for the assessment of comorbidity and 1 for symptom distress, and 4 for palliative care needs, and 2 for the assessment of quality of life. And there are also different tools for the assessment of care distress, cognition assessment, and hospitalization factors. Now I would like to briefly talk about the intervention programs that we have identified in our review to enhance end-of-life care for older people presented to the emergency department. As we can see in this bar chart here, there are 3 interventions that we have identified in our review, and those included JEDI-WISE program, rapid standardized 2-stage screening, and pilot palliative care program. And as we can see in the table on the right-hand corner in this slide here, benefits actually were reported in this intervention program in our included studies. And this includes, it helps to lower the inpatient admission and readmission rates and the emergency department length of stay and the emergency department representation rates and cost saving. Also, it actually helps to improve the timing and appropriate referral to palliative care and hospice care and symptom management at the end of their life for older people presented to the emergency department. So I would like to acknowledge the limitations of our review. So despite the rigor that we used for our review, there are still limitations that we would like to acknowledge. So first, we only included English articles due to the limited time and resources for translation. And second, we only focused on the peer review articles. There was no great literature involved in our review. Third, we did not include qualitative studies due to the scope of this review. And last, we also did not focus on the specific types of the disease, such as dementia, cancer, heart failure, as this review broadly focused on older people presenting to the emergency department at the end of their life. So the take-home message of this presentation today is that overall, the key findings of this review is, first, end-of-life care definition is limited in most studies in our review, even though end-of-life care is well defined in the policies and guidelines. And it is evident in this review that older people presented to the emergency department at the end of their life have multiple comorbidities and symptom burdens. And it's also essential to use several screening tools to guide the end-of-life care decision-making rather than using a single tool. And there were also three interventional programs that we identified in this review, reporting positive outcomes. And one of the key findings in our review is that there is a limited information regarding if or how policies and guidelines were followed. So future research should take policies and guidelines into consideration when developing and implementing intervention programs. So finally, we would like to acknowledge Sarah Thorning. Sarah is our research and teaching librarian at Gold Coast University Hospital. She helped with the search strategies during the development of our review protocol to ensure the search strategy was rigorous and transparent. So now it's the end of my presentation, and I'm welcome to any questions that I can answer with regards to this scoping review.